Good evening, good afternoon, good morning, everybody. A very warm welcome to this IACH educational webinar dedicated to a topic of critical importance in the field of hematology and transplantation, the management of CMV infection. CMV remains one of the most significant infectious complications in immunocompromised patients, particularly in the context of allogeneic stem cell transplantation. And despite advances in prophylaxis and preemptive therapy, CMV continues to challenge clinicians around the world with its complex pathophysiology, evolving resistance patterns, and the delicate balance between immune reconstitution and viral control. I'm Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris in France. And it is my great pleasure and honor to moderate this webinar. And we're truly honored today to be joined by a world-renowned expert in the field, Professor Per Lungman. Professor Lungman is a pioneer in infectious complications of transplantation and a leading voice in the international hematology and infectious diseases communities. His groundbreaking work has shaped how we approach CMV management, from diagnostics and prevention strategies to therapeutic interventions and long-term outcomes. Tonight, he will guide us through the latest evidence, clinical insights, but also future directions in CMV management, especially in light of the most recent ECIL recommendations. His talk promises to be both educational and highly relevant to daily clinical practice, and you will have the opportunity to ask your questions at the end of the webinar live to Professor Lungman. So, Per, thank you for being with us today. The floor is yours.
Thank you, Mohammed, for the introduction. So, thank you very much. I'm Per Lungman. I'm from the Karolinska University Hospital and Karolinska Institutet in Stockholm, Sweden. And Mohammed has clearly and nicely introduced the field. These are my disclosures. So, as already has been outlined by Mohammed, CMV has been a challenge for many decades after allogeneic stem cell transplants. It's been called the troll of transplantation, and management strategies must therefore be in place at all allogeneic transplant centers. So, as already introduced, I'm going to talk about the most recent guidelines, not only in stem cell transplant, but I will also finish off a little bit about CMV in some of the new therapeutic arenas, such as CAR T cells and bispecific antibodies. The European Conference on Infection in Leukemia, or ECIL, was created by Catherine Cordonnier from Créteil in France. And the aim has been to produce evidence-based European guidelines. We did a previous edition of CMV, which was published in 2019. So that is now 6 years ago. And of course, a lot has happened since 2017. Letermovir, which I will get back to, has become widely available. Another antiviral, maribavir, has been licensed. We have learned more about CMV serostatus and CMV pathogenesis. And as I already alluded to, new patient groups have become of interest regarding CMV as a pathogen. To address these issues, the ECIL created a working group with the names, as you can see to the right, and recommendations were discussed and decided at the meeting in September 2024. These guidelines were published about 2 months ago in the Lancet Infectious Diseases, where they are available for more detailed study. Go back then to CMV and allogeneic transplant. Well, it has been known for many years that to best manage patients, we need to know not only the serostatus of the patient, but also the serostatus of the donor. And the practice has been that when a patient is being evaluated for transplant, you check the serostatus, and then you either classify the patient as positive or CMV negative, and you might manage the patient accordingly. But the importance, and rather when you should look at CMV serostatus, has been challenged more recently by two studies. This is a study from Geneva in Switzerland, retrospective study, 291 patients. But what they did, they looked at the serostatus pre-transplant. This is the percentage is high, but it's typical for the population they serve. But they also went back and looked at the sample at diagnosis of the hematological disease that was an indication for transplant. And they found that if the patient was CMV seronegative at the first sample, and then CMV seropositive at the second sample, they reclassified the patient as being seronegative. And that was done in 24% of the patients. But interestingly enough, they not only did this, they also acted upon it. Namely, they gave no letermovir prophylaxis. And in the end, there was no difference in the risk of CMV DNA in the reclassified group as being CMV seronegative as in the patients who were seronegative from the beginning. Another study was done in Toronto in Canada in a slightly different design, but on the other hand, in a much larger cohort, almost more than 750 patients. They found that about 89 patients, 12% of the patients had changed from seronegative to positive, but also that there actually were patients that were from the beginning seropositive that had lost antibodies. And instead of 25%, as in the Swiss study, they reclassified 12% from the seronegative, from the seropositive to seronegative status. And they then, this was without letermovir, but the risk for CMV reactivation was the same in the reclassified seronegative patients as in the so-called true seronegative patients. And in the ones that had lost their antibodies, they were more like the seropositives, but not quite. But they reactivated CMV in almost 50%. So these two studies, and there are also a couple of other smaller studies, say similar things, resulted in that ECIL has changed its recommendation, namely that CMV serostatus should be checked as early as possible when a diagnosis that might be an indication for stem cell transplant, and before transfusion or immunoglobulin or anything else that could result in passively transfer of antibodies. The patient should be tested very early. And then also, of course, before the transplant. And it's also recommended to do a PCR just before transplant. Of course, when patients are coming now, you might not have this early sample, and then you have to use your clinical judgment whether or not to give antiviral prophylaxis. But if a patient is seronegative at diagnosis and particularly if they are weakly seropositive coming to transplant. The studies that has been performed seem that you can safely withhold antiviral prophylaxis. But in the majority of patients, of course, they will be true seropositives, and therefore we in ECIL addressed and discussed a lot about what is the best way to today use the drug of letermovir. As you certainly know, letermovir is a new antiviral with a different mode of action compared to previous classic antivirus. It works very late in the replication cycle on the so-called CMV terminase. And we today know that letermovir can control CMV in the majority of seropositive patients. Why is this important? Well, this is important because of what Mohammed Moti said from the beginning, that CMV is a very important pathogen. And this study from the Seattle group, published now almost a decade ago, clearly showed that there is no safe level of CMV viremia or CMV DNAemia. Any viral load in this retrospective study had an effect on mortality. I'm sure that most of you have seen this paper and this picture before. This is the pivotal study that resulted to the licensing of letermovir, both in the US, within the EU, in the UK, and in many other countries. It used a new concept at the time when it was designed, and that is what's called clinically significant CMV infection, meaning CMV disease or requirement for preemptive therapy. And the unique with these results is that letermovir was protective not only during the 14 weeks it was given, but also in the subsequent 10 weeks after discontinuation, and the difference was highly significant compared to the placebo group. Many studies have been performed since, so-called real-life studies, and this is from a publication looking at systematic review and meta-analysis performed by Roy Cemali at MD Anderson and his colleagues, summarizing up until 2022 all the interesting studies. And what they could show was not only was the effect on clinically significant CMV infection verified, but it was actually protective against CMV reactivation at any level and also reduced the risk for CMV disease. The important thing in the pivotal study by Marty et al. Was that not only did letermovir prevent clinically significant CMV infection, it also, at 6 months after transplant, had reduced all-cause mortality. This was also looked at by the authors of the systematic review and meta-analysis, and similarly, not very early after transplant, but later out after transplant, it reduced all-cause mortality. In this case, beyond day 200, so more than 6 months, with in most cases, letermovir was given for 3 months. It also reduced non-relapse mortality, but also very interesting, the grade 2 or more acute GvHD. There's been a long-standing discussion if CMV drives acute GvHD or if acute GvHD drives CMV, and this analysis would support that at least there is a positive effect to reduce the risk for GvHD by controlling CMV. When to start prophylaxis? Well, that is rather difficult to answer because no study has critically assessed when it should be started between day +1 and day 28, which is the current label for letermovir in both the US and Europe. What we know is that fewer so-called letermovir blips are seen when you start very early after transplant, and I will get back to that. And we can also say that it's absolute certain that you lower the risk of early reactivation, as was seen in the non-pivotal cohort of the MARTI study, where it was a clear difference in the risk for CMV in the patients that were PCR positive when letermovir was started, and in those who were not, as you can see in the figure to your right. So how did ECIL summarize these results? Well, it is recommended as a strategy of choice in CMV seropositive adult allogeneic stem cell transplant patients. I will get back to children a little bit later. We decided to recommend it to start as early after transplant as feasible to reduce the risk of early reactivations. This is a weaker statement with so-called B2 evidence and recommendation, but we felt that the data supported it, and it should be continued as long as was done in the pivotal study, meaning at least 100 days. What about prolonged prophylaxis? This is the high-risk subgroup in the pivotal study, and as you clearly can see after the green shaded area, which was the duration of letermovir, when it was stopped, the letermovir patients reactivated at quite a substantial rate, although still remained less likely to have clinically significant CMV than the placebo group. So what would be the effect if it was given longer? Well, this has also been studied in the randomized placebo-controlled trial. This is the so-called Russo study published in Lancet Hematology. And everybody got open label letermovir for the first 100 days and then randomized to either receive another 100 days or stopped at week 14. And then the patients were followed until 48 weeks after transplant. This study used the high-risk cohort from the early pivotal study, so the standard risk patients, so to speak, were not included in this trial. And these are the results. I show the results from the secondary endpoint, which was time to onset of clinically significant CMV infection, but there was no difference with the primary endpoint, which were proportions of patients with clinically significant CMV. And this illustrates very clearly that as long as you give letermovir, CMV is controlled, but when you stop it, even if you stop it after 6 months, you will still see quite a lot of reactivation. And in fact, there was no longer a significant difference in the rate at week 38. Important result of this study was that there was no increased risk for side effects by giving letermovir longer, clearly supporting that letermovir is a drug with a limited risk for important toxicity. Looking at mortality, which was then significantly different in the pivotal study, there was no mortality difference in this extension study, but the number of patients were not large enough to really say that with any certainty. But as you can see, there is not even a trend for increased mortality in the placebo group. So I think this supports that CMV is the most dangerous as a pathogen early after transplant. And when you come further out, yes, it can still cause problems, but it does it in fewer and fewer patients. So these are the ECIL recommendation that it should be considered in patients at high risk for CMV disease, and you can think about which patient that can be. It could be patients with acute GVHD at day 100. It could be mismatch unrelated donors. It could be haploidentical transplants, possibly cord blood transplants. And there are some studies, particularly from Memorial Sloan Kettering in New York, that suggest that in the really high risk group, now we are talking a small proportion of patients at really high risk, it can be used for longer than 200 days. What about CMV seronegative patients with positive donor? Well, there is no study looking at that, so it is not recommended. I mentioned the letermovir blips, and these are single test low-level DNA positivity, particularly early after starting the letermovir. And this has to do with the mechanism of action of the letermovir, which accepts some DNA synthesis, but no synthesis of complete variants. And I get back to drug-to-drug interactions in a minute. So how do we separate blips from reactivations? Well, this is, some way of looking at it. There certainly happens real reactivations. They usually have increasing viral load, higher viral load, and more than one positive test. And the opposite then is true for so-called blips. The letermovir has definitely some drug-to-drug interactions. It acts on some CYPs. It acts on the P-glycoprotein. So particularly cyclosporin, of course, is a well-known interacting agent with the letermovir, and therefore you need to dose adjust when you give the two together, but it also has effects on tacrolimus and sirolimus. There is a clinically relevant interaction with voriconazole, but not with posaconazole, and the knowledge about isovaconazole is less at this time. But there are also other interactions, rifampicin, repaglinide, and omeprazole. So you have to check the SPC. What about therapy with the letermovir? Well, there's never been any good study. We have no idea what the therapeutic dose should be, and the risk for resistance in the clinical examples where it has been used, particularly after solid organ transplant patient, does not support its use because the bar for resistance development is quite low. If you have not given letermovir as primary prophylaxis, or if the patient reactivates after letermovir has been stopped, you could think about secondary prophylaxis. There was a study from France published early after the licensing of letermovir, and this is a more recent study from the US suggesting that the risk for letermovir resistance is low if you reuse letermovir. But resistance, as I already has mentioned, does exist, and particularly if there is a breakthrough on letermovir with rapidly increasing viral load, you should consider the risk for resistance and send a sample for resistance testing if you have that possibility in your center. What about children? Well, just as we were working on it, it became likely that the letermovir would be approved in children, and we therefore gave a positive recommendation, and that has after that been echoed by the CHMP of the EMA, and the letermovir in children has now been approved by the European Commission if the child weighs more than 15 kilograms. The duration of prophylaxis should be considered the same as in adults, although the data, of course, is much weaker. This is a summary that my colleague Jan Styczynski put together when we worked on this recommendation, and these are what was out in the literature by now about 10 months ago, and there's no difference in the efficacy in children and adults when using letermovir. This is a very tentative recommendation of doses in children. And as I said, at least in the European Union, it's only licensed for above 15 kilogram because the knowledge about smaller children with lower body weight is much more limited. There is a work of so-called pellets, but they are, to my knowledge, not yet available. But when they are, it's going to be easier to administer the letermovir to children. What about then monitoring and preemptive therapy? Well, letermovir, as you have seen, is not 100% effective. So monitoring should be done in all allogeneic transplant patients. You should consider extended monitoring in high-risk patients, particularly those on haploidentical transplants and on those with GVHD. Monitoring should be done in the same laboratory with the same platform because there is still significant variability between different laboratories in levels of CMV DNA that the different techniques detect. And we had a lot of discussions whether or not we could recommend a viral load when preemptive therapy should be introduced. And because of the variability, we said we cannot do that. It has to be done on the central level and probably also tailored to the different patients. Regarding preemptive therapy, most of these recommendations are exactly the same as in 2019. We added maribavir since there is a randomized controlled trial between maribavir and valganciclovir, where maribavir did not reach non-inferiority, so we didn't give it a general recommendation, but in certain situations, particularly in patients with either renal toxicity or severe bone marrow toxicity, it can be considered. With letermovir, the problem of refractory resistant infectious disease has become much less, at least in our hands at Karolinska. It's now single patients per year where we really have significant ongoing CMV problems, usually in patients with bad GVHD that has required repeated courses of antiviral therapy. We strongly recommend testing because there is a much more common situation that the patient is so-called refractory, meaning doesn't go down in viral load, rather than true resistance. And if you act on what you think is a resistant infection, but it really is not, the change of antiviral drug can actually be negative for the patient. Here, on the other hand, we have maribavir with a very strong recommendation in resistant refractory infections and disease because it has been shown in a randomized controlled trial to be less toxic and more effective than other alternatives that it was compared to in that trial. Maribavir doesn't pass through the blood-brain barrier, so it's not useful for infection in the CNS. And unfortunately, a little bit similar like letermovir, but much more substance in that data, there is a risk for resistant development, particularly in patients not responding. And that's another indication for testing. If you don't use maribavir, there are other options. Foscarnet is the classic option with, as you know, certainly toxicity problems. CMV-specific T cells can be an option in treatment of resistant refractory CMV if available. I've already said that you should not use letermovir, and you should never use the combination of maribavir with ganciclovir because they are antagonistic. Here we have the pediatric situation. Here, maribavir is in the US allowed for pediatric or licensed for pediatric patients about 12. In Europe, it is the 18 in the EU, but it is a drug with limited side effects, so it should be safe to use also in children. This is an algorithm that exists in the paper. I'm not going to go through it in detail, but you can look it up if you have refractory CMV or CMV with different mutations, either in the UL97, which is the gene where resistance to ganciclovir and maribavir can occur, or UL54, where the resistance for ganciclovir for scarnet or cidofovir can occur. And then you can see what the different options can be in the rare cases of very resistant refractory CMV. As I started saying, we also discuss other topics at ECIL, and I will briefly go through these three topics: immune monitoring, CAR T cells, and patients treated with bispecific antibodies. As you know, there are commercial tests available to look CMV specific immunity. We went through the literature on the published assays, and we don't think they are ready for prime time yet. There are certainly positive results that can be used, and there are several cohort studies and retrospective studies showing that this can be helpful in management, but really no randomized controlled trial. So we have kept the recommendations on the optional stage, which is the category C. Of course, all of us are interested in what happens in CAR T cells, clearly are several reports out there showing that CMV can reactivate, particularly early after CAR T cell therapy in heavily pretreated patients and in patients with CRS. These are the risk factors for reactivation. But the question is, what should we do about it? Well, other guidelines specifically directed to CAR T cells have suggested active monitoring, particularly the early phase after transplant, and ECIL agree with that, particularly in high-risk patients. The need to give preemptive antiviral treatment is not proven. The clinically significant CMV infection concept has not been defined for CAR T cells. So it can be done, but it is also possible to wait for symptomatic CMV because end organ disease is rare in CAR T cells. Most patients develop fever, and that can easily be managed with antiviral therapy if needed. Prophylaxis is not recommended. And going into T cell engaging antibodies or specific antibodies, the knowledge is even less. Most of the data exists for multiple myeloma. There are clearly reports on CMV end organ disease, not only in myeloma patients with bispecific antibodies, but also with other modern anti-myeloma drugs. But how to deal with this is still unclear, and we definitely need more studies and more evidence. So therefore, the degree of recommendations how to deal with these patients is much lower, and prophylaxis or routine preemptive therapy neither is recommended at this time. So to conclude my presentation, antiviral prophylaxis with letermovir and early detection through monitoring has significantly improved outcome if you go back 10 years or so. the drug of choice is letermovir. The possibility to now give it to children is a major step forward. However, we still have challenges. How to really deal with long-term consequences has not been well studied. There is a nice study from the Seattle group that long-term low-level CMV replication is associated with poor outcome. We also know that the patients reactivating late after long-term letermovir prophylaxis have some deficient immune reconstitution. So can we improve management? The question about using immune markers, well, I also already alluded to that we need good trials, and it could be also be an indication for virus-specific T cells, but they are not available at all sites or for all patients. So we need additional studies. There are 2 CMV vaccines actually in development, one being tested in Boston in stem cell transplant patients, the other one being tested at City of Hope and other US centers. And we'll have to wait for the results and see if any vaccine becomes available. And more work is needed when we talk about management of CMV treated with CAR T cells or bispecific antibodies. But CMV has clearly shown that it is able to bounce back, even if we think we have found a solution that will control CMV in all our patients. It has not been through, unfortunately. So those of us interested in CMV will have still work to be done. And with that, I thank you for your attention with this quotation about if you know what the difference is between education and experience. And I hope you now has received some education on this topic that you can then use for your experience. Thank you very much.
Thank you very much, Per, for really beautiful and very comprehensive talk. We have a few questions, if you don't mind. First question, and of course, you mentioned the good news about now the possibility to use it in children. And obviously, in children, sometimes it's a bit tricky to take pills and oral drugs. So we have a few questions about the absorption. Do we face any issues of absorption when it comes to letermovir? Are there any interactions with specific food?
Yeah, well, I'm not a pediatrician in the first place, but my colleagues and the way we do is that we are, you can either, of course, use the IV, letermovir. That's the easy part. Then you don't have to think about what you just mentioned, but it's not available everywhere and it's quite expensive. I know that we in Sweden have smaller tablets that we can crush and give in the nasogastric tube, for example. So, but I'm no personal experience with that. This is what my pediatric colleagues tell me. No, there is no interaction with food or anything like that. The problem with the letermovir is that some patients get nausea. That's the only really common toxicity with letermovir is GI intolerability. And I don't know if that is a bigger problem in children or not.
Excellent. Thank you very much. Are there any group of patients where you would go with letermovir beyond day 100, as it has been shown by Russo and colleagues?
Yeah, I can say what our standard operating procedure is at Karolinska. We don't upfront determine a duration of letermovir, except that everybody should have 100 days, unless there is a breakthrough, which is very rare. We start at day +1 in all patients, and the number of patients where we get reactivations are exceedingly small. Then we look at the patient come for their 3-month checkup. If there is a standard risk patient, no GVHD, nothing in particular, we stop letermovir. if they're patients with high-dose steroids, ongoing acute GVHD, very low lymphocyte count, high-risk patient, haplo, whatever, we continue for another month. Then we look again at 4 months and make the same assessment, and then at 5 months and at 6 months. So we are tailoring our prophylaxis to the individual patient rather than to a fixed duration. Because as was clearly shown by the Russell study, whenever you stop, you need to be able to handle CMV, or the patient need to be handled CMV. So it makes sense to us to have a individual duration.
Thank you. Another question, which is actually in relation with this increasing use of letermovir, is about the value of having CMV negative blood products or irradiated blood products to avoid the risk of CMV reactivation, given the fact we can give letermovir and the incidence of infection reactivation is going to be
okay.
low.
That has never been studied. Of course, the irradiated blood products has nothing to do with CMV. It has to do with the risk of GVHD due to the blood products. So irradiation remains definitely the recommendation. In Sweden, which is where I work, this is not everybody gets filtered blood products. That's routine, because you don't only filter away CMV, you filter away a bunch of other things as well that can be transferred by leukocytes. So I wouldn't, but if your routine has been to do sort of both with bracelet and the belt, so that you say filtered CMV negative blood products, I don't think that's necessary any longer. I think you definitely can stick to only leukocyte depleted blood products.
Excellent, thank you. Actually, we have another question in the same line because historically the CMV serostatus between recipient and donor has been important when selecting a given donor. Is this something relevant? So maybe what is the weight of CMV serostatus today when choosing a donor based on what we have in prophylaxis?
Yeah. Well, yeah, on the purely medical ground, if you have a true CMV seropositive patient, if you can, we choose a CMV seropositive donor, because then you transfer immunity with the donor. So that is the post-pos situation. If you have a negative patient, how risky is it to use a positive donor? Well, letermovir has not really changed that, because we don't give letermovir in that situation. So until now, we have not changed in ECIL our recommendation that if you can, you should use a donor of the same serostatus as the patient. But of course, it is of interest, this reclassification of serostatus. So if you believe that you have a positive patient and in reality you have a negative patient because there was antibodies, passively transferred antibodies, that could make a difference. But these things needs to be formally studied, and the best we have are the 2 studies I showed you from Geneva and Toronto.
Thank you, Per. Another question here we have, and actually at least 3 colleagues asked this question. Is there a link between EBV reactivation and the use of letermovir?
This has been come up in a number of abstracts from China. It has been both in the EBMT meeting in Glasgow and the EBMT meeting in Florence, a couple of publications. So far, it seems to be mainly a Chinese phenomenon. If you look at those studies, they have used the classic Chinese way of doing haplotransplant with high-dose ATG. And there was a recent presentation at the tandem meetings from MD Anderson, which has not seen it. They have looked at it at Memorial. They have not seen it. They have looked at it in Seattle. They have not seen it. We have not seen it. We also have looked in Stockholm. So I think the question is not closed. There really need to be additional studies, but I think the risk of EBV definitely is less than the positive effect of the Thermovich, which I think is the key issue here. Another interesting question, which of course could be, but that also needs study, but it has come up as at least as an hypothesis to explain the Chinese results if it's not the way they do haplo, and that is there anything specific in the drug metabolism if you have come from a Chinese genetic background? And there was some very early discussions with letermovir. So the pivotal study was actually stopped for a while in China, Japan, and Korea while they tried to sort this out. Then it was restarted again. So I'm not excluding that there is something, but if you work in a European center or North American center, the risk doesn't seem to be great anyhow.
Thank you. And I'll take another two questions, actually. What is the pattern of resistance now that we have been using letermovir since 6-7 years you see after letermovir prophylaxis?
It's single percent. It's been tested in both by the Seattle group and in other large studies. If you know, it's the same as with all antiviral drugs. If you underdose, either through that you give the wrong dose or that the patient doesn't comply, take occasional tablets, or if there's a problem with absorption with lot of diarrheas, for example, you can always underdose. The same goes with valganciclovir, for example, and acyclovir as well. So, but the experience is very few, single percent level.
Okay. If you don't mind, two other questions, actually. Are there any interaction in those patients receiving HIV, anti-HIV drugs? Are there any interactions with letermovir?
I'm not an expert that can tell. We have had a couple of patients coming through transplant. We changed that were HIV positive. We changed their prophylaxis or their treatment of HIV, but mainly due to other drug interactions than the one with letermovir. I think you have to sit down with an HIV expert and pick the proper regimen.
Excellent. Well, that is so that was a question from Dr. Burke. Yeah. So last question about the future. You mentioned in your conclusion the development of CMV vaccines. So when it comes to donor and the recipient, who you would vaccinate? Is it the donor?
Yeah, that's a very interesting point. There are two vaccines that are being studied. One is the mRNA vaccine from Moderna, and that is being studied in Boston at the moment. They are vaccinating patients after transplant in a phase 2 type study. The other one is the vaccine from City of Hope, and that one was studied in donors. It has been published, and they look at both donor and recipient vaccination. So we'll see. Well, none of them is available. Both of them are being studied, and we'll see. I think the Moderna vaccine, if it comes to the market or not, will depend on what happens in the studies of vaccinating young women to prevent congenital CMV. The triplex or the City of Hope vaccine from Don Diamond's group, they are targeting transplants more strictly. It's both in stem cell transplant, and they also have an ongoing, quite large study in liver transplants.
Well, I think we're coming to the end of this ICH webinar. I'd like to sincerely thank Professor Lungman and all of you for your active participation and engagement. I believe today's session has once again reminded us how CMV remains a great challenge in hematology and transplantation, despite significant progress. Professor Lungman reviewed key updates from prevention to emerging antivirals and the role of and importance of immune monitoring, highlighting not only, I think, how far we've come, but also how much remains to be done. Managing CMV is a truly, I would say, balancing act between efficacy and toxicity, early detection, and over treatment, and definitely it requires the ongoing education and innovation. I'm deeply grateful to Professor Lungman, who shared his fantastic expertise. And at the end of the day, the goal is about improving care for patients worldwide. So let's continue to share knowledge, challenge dogmas, and support one another in advancing the field. Thank you again. I look forward to seeing many of you at our future ICH events. Take care and goodbye.